Hello friends, I am Dr. Krishna Patil. I am a consultant nephrologist at Sunshine Hospital's Gachibowli, Hyderabad. Today I am going to discuss a very important topic, that is reversing type 2 diabetes, whether it's a fad, a popularity gimmick, or is there a scientific basis or evidence. So let's look at the scientific evidence of type 2 diabetes today, or reversing type 2 diabetes today. In last 1 year, we have seen the scientific community working hard in fast tracking of the COVID-19 vaccine. The vaccines used to take a decade to come into market, but in last 1 year, when the whole world was plagued by this pandemic, we aggressively went behind it and got the vaccine. The same aggression has to be applied in dealing with this pandemic of diabetes and obesity. We need to fast track the knowledge or the understanding of type 2 diabetes and how we deal with it to prevent and reverse type 2 diabetes. As you all know, type 2 diabetes is a disease of insulin resistance. This picture clearly tells the role of insulin in type 2 diabetes. This is a patient with type 1 diabetes where it is insulin deficient state. The body is unable to produce insulin, and insulin is a nutrient storing hormone, and devoid of insulin, a person wastes away. It's classically described as wasting away one's muscle and fat in the urine, and the person becomes emaciated. Whereas we all know type 2 diabetics are generally obese. Most of them are obese, and this is a state of hyperinsulinemia or excess insulin in the body. So insulin is the key hormone governing our weight or obesity, and devoid of it, a person gets emaciated, and excess of it causes obesity. So despite of other hormones like cortisol, which cause insulin resistance also, and stress plays a significant role in causing increased cortisol exposure to the cells, causing insulin resistance. That's another mechanism for insulin resistance. But the biggest player here is insulin itself, causing insulin resistance and obesity. Let's look at some studies of diabetes prevention. So there have been multiple studies looking at how to prevent diabetes, and the most popular amongst them are the Finnish Diabetes Prevention Study and the Diabetes Prevention Program, which had over 500 and over 3,000 individuals enrolled in the age group of 50 and 55, and they were clearly obese with a BMI of over 30, and the intervention was either lifestyle modification and metformin, and there were 3 groups here: lifestyle modification, metformin, and placebo. And the study was a 3-year duration study, and it was seen that those who lost 3.5 kilos of weight, 11% of them became diabetic, whereas those who did not lose weight, 23% were diabetic. So a 50% reduction in the prevalence of diabetes, incidence of diabetes, because of weight loss. And in this study, with the 5 kilo weight loss, 14% progressing to diabetes and 29% progressing in those who did not lose weight. And in metformin group, it was 22%. So clearly, lifestyle modification or weight loss can prevent the onset of diabetes, and 50% of them can be prevented from going to diabetes by just 3 to 5 kilos of weight loss. So weight has something to do with diabetes. It's the most important factor which causes type 2 diabetes. So looking at the bariatric surgery results in last decade, the thought about reversing type 2 diabetes has started to gain momentum, because we have been seeing reversal of type 2 diabetes with bariatric surgeries. In this study, this was a meta-analysis of over 600 studies with over 1.35 lakh population who underwent bariatric surgery and lost around 30 kgs of weight. And what was seen that 80% of these who lost significant weight after bariatric surgery had a reversal of type 2 diabetes. They were diabetic for a long time. And 80% of them could reverse their diabetes because of weight loss after bariatric surgery. And they did not just become off all the diabetes medication, but it was sustained diabetes reversal beyond 2 years. Not all bariatric surgeries had this benefit. It were the sleeve gastrectomy and the Roux-en-Y gastric bypass. These two surgeries offered the maximum benefit of diabetes reversal. The point here is diabetes is not irreversible. Bariatric surgeries have proved that diabetes can be reversed, and if bariatric surgery can do that, why not intensive dietary management and lifestyle modification can do it? And we probably are failing somewhere in dealing with this diabetes pandemic. Our approach probably needs to be changed. This study, which was recently published in December 2020 in NEJM, looking at solving the population-wide obesity problem, it clearly mentioned, the headline was, since mid-1970s, the obesity has tripled. The prevalence of obesity has gone threefold up after 1970s. And diabetes is not just associated with, obesity is not just associated with diabetes, it's linked with cancers as well. 40% of the uterine cancers, 10% of gallbladder, kidney, liver and colon cancers are due to diabetes. 40% of cardiac events or heart attacks are because of diabetes. And most of the cases of type 2 diabetes are because of diabetes. In the US population, 42% of adults are obese. In their 2 to 5 year age group children, 14% are obese. And 6 to 19 age group children, 20% are obese. In our own observation, I was a part of a study in Calcutta where we screened around 10,000 urban school children for obesity, hypertension and urinary abnormalities, and we found 20% of our Indian urban school children are overweight or obese, and around 3 to 4% are hypertensive. So we are sitting on a huge ticking time bomb of pandemic of obesity and diabetes. And if we don't act now in preventing obesity and diabetes, we need to modify our strategies. We clearly are missing out on something. If we look at the timeline, this was again published in the same article in NEJM, where it looked at the timeline. The nutritional guidelines started to come in 1970s in US and globally. This is the time where the food market, the food industry was growing, and the processed foods have occupied all the grocery shops and malls. And we are being promoted, the processed foods. And the nutritional guidelines also started looking at the atherosclerosis, the fat deposition in the arteries, and demonizing the fat, that we should reduce the fat, the caloric intake from fat to less than 20% and increase our caloric intake from carbohydrates instead to around 60 to 65%. This is the timeline when this change in nutritional guidelines came in. And if you see, after 1970s and 80s, the obesity pandemic has progressively exponentially worsened. And in US, where in 1960s, 70s and early 80s, the adult population had 15% obesity, now it has reached 40% of adults being obese. So clearly, we are probably not giving correct advice, and our advice is probably biased by the food industry. Our focus has been long time on hyperglycemia management. Last 4 to 5 decades, we have done great advancement in managing the fasting post-lunch glucose levels and HbA1c with a wide range of drugs available the oral hypoglycemic agents and the wide range of insulins available, but we have failed in preventing mortality, giving mortality benefits, preventing kidney disease, preventing obesity, preventing heart disease. And we need to look into whether it's only the hyperglycemia management or the insulin resistance which goes on progressively worsening needs to be managed. Our mindset has to change. The 19th and 20th century mindset was of treating with medicines, curing with medicines. Those were the centuries where infections were the primary cause of death and antibiotics came in as saviors, and people started looking at doctors as saviors, those who give medicines, and the doctor's mindset was patient comes, you give medicine and cure them. But the same mindset has been applied to these lifestyle disorders. And these lifestyle disorders, we have been treating them with medication after medication, but have not been focusing or devoting our time on counseling about intensive dietary management and lifestyle modification. And these are the diseases of lifestyle and diet, and have to be dealt with these interventions rather than medicines. And that's the reason why we have been miserably failing, despite of so much scientific advancement that we have reached the moon, but we have not been able to manage diabetes and obesity for last 5 decades. So our focus has been on hyperglycemia. Yes, glucose control is important, because the more the glucose in the blood, the advanced glycation end products, the glycation of the cellular level, causing the cell injury and preventing that hyperglycemia related cell injury is important, but not at the expense of worsening the insulin resistance and hyperinsulinemia. And hyperinsulinemia, the insulin is the fat storing hormone, which is the key in causing the fatty liver, the atherosclerosis, obesity, fatty kidney disease, as we now understand as fat deposition in the kidneys, causing progression of this chronic diabetic kidney disease. And so hyperinsulinemia is the most neglected aspect of our diabetes management, which needs attention. And this has now been addressed in the new guidelines from ADA, where they not look at the hyperglycemia, but the insulin resistance and hyperinsulinemia as the cause for the atherosclerotic cardiovascular disease and heart failure, and the organ injuries like micro and macrovascular complications from diabetes. And if you look at these guidelines from ADA 2020, first line therapy is still metformin and comprehensive lifestyle, including weight management. That continues to be the first line therapy, metformin. And what are being preferred are the SGLT2 inhibitors and the GLP-1 analogs, which promote weight loss. Drugs which cause weight gain do not give mortality benefit, do not prevent cardiovascular events, and the drugs which are reducing weight, like the SGLT2 inhibitors and GLP-1 analogs, they are the drugs which are pushing the glucose out of the body through urine, like SGLT2 inhibitors, or preventing glucose entry into the body, like the GLP-1 analogs, causing anorexia or decreasing appetite, and metformin, which decreases the production of glucose in the body by preventing gluconeogenesis. So insulin just pushes the glucose inside the cells and inside the liver as glycogen and converts the excess into fat. So it is storing the glucose and not eliminating glucose from the system. So fasting can be a key or the most potent medicine by reducing glucose input into the body and preventing cardiovascular events, like the GLP-1 analogs and the SGLT2 inhibitors are giving cardiovascular benefits. The same way, fasting could be a potent intervention. Let's look at what is the cause of this obesity and insulin resistance. For a long time, we have been thinking that obesity is the cause of insulin resistance, and insulin resistance leads to hyperinsulinemia. But now we have started thinking the other way around. It's probably the hyperinsulinemia which drives insulin resistance and obesity. And why do we think so? This is a reinforcing cycle of resistance. Overexposure of insulin to the cells causes insulin resistance, and insulin resistance leads to further increase insulin levels. To achieve that glycemic control, the body produces more insulin, and more insulin causes further insulin resistance. And insulin, being fattening hormone, causes obesity and causing further insulin resistance. So insulin resistance, the key driver is the insulin itself. And why do we say so? If we look at insulinoma, it's a rare tumor of pancreatic beta cells where the tumor is secreting excess of insulin. And if you look, these patients just don't die with seizures from hypoglycemia, because body has a protective mechanism. When body is producing excess insulin, the insulin resistance also progressively increases. As the insulin levels go up, the insulin resistance also worsens. And that's a protective mechanism because of which these patients survive. So insulin excess itself drives insulin resistance. If you look at these euglycemic clamp studies where you infuse glucose and then infuse insulin and maintain euglycemia by giving continuously insulin, when the euglycemia is maintained, if you see over the 6-hour period, the insulin requirement progressively goes up. There is a 15 to 20% increase in insulin resistance because of the persistent insulinemia. The to maintain that glycemic control, if you keep on giving insulin, the cells become more and more insulin resistant. So 15 to 20% insulin resistance was observed within 6 hours of continuously giving insulin. So insulin is the key driver for insulin resistance. In 1990s, where insulins were famous for reducing hyperglycemia, and we were chasing the targets stringently by achieving good glycemic control using insulin, what was observed in studies, as the patient is started on insulin, after 1 month, if they were not on insulin, and then at 1 month they were on 86 units insulin, at 3 months they were on 92 units of insulin, at 6 months they were on 100 units of insulin. So insulin requirement progressively goes up with time. And if you can see, they gained around 8.6 kilograms of weight despite of caloric requirement going down. So they were consuming 2000 calories to begin with, and here they were at 6 months consuming 1700 calories. The 300 calories less, but still a weight gain of 8 to 9 kilograms. So insulin is a fattening hormone which causes insulin resistance and further increased requirement of insulin. So this is very important to understand, that insulin inherently inhibits glycogenolysis, inhibits gluconeogenesis, and it stimulates de novo lipogenesis. It inhibits lipolysis, inhibits breakdown of our stores. It is a storage hormone. As we eat, the body gets a signal. Nutrients are coming in, store the nutrients. And that message is given by increasing the insulin level in our blood. And it stores the glucose in the form of glycogen in the liver, and the excess is further converted by de novo lipogenesis into fat in the liver. And when we are in a fasting state, we are not eating, this stored, the insulin levels dip, and this can be the stimulus for the counter-regulatory hormones to come into picture to burn the stored sugar in the liver by glucagon, adrenaline. These hormones come into picture and they cause burning of the sugar from the liver and burning of the fat eventually. So insulin levels have to dip for the stores to be broken. Insulin puts a lock to the stores. Insulin locks the stores. It inhibits lipolysis. If you look at how our body deals with the different nutrients, if you look at the carbohydrates, when they are absorbed through our intestines, they go to the liver. The proteins, when they are absorbed through our intestines, they go to the liver. But if you look at the fats, the long chain fatty acids, they don't go to the liver because body doesn't want to clog the liver with fat. Body has a separate pathway to absorb the fats and send it to its appropriate position, place. So fats enter into the lymphatic channels, into the thoracic duct and into the venous system, and then they are transported to the adipocytes, the subcutaneous adipocytes, which are the natural place for fat storage. And muscles, the resting muscles, the preferred energy or the fuel is the fatty acids, and they are sent to those sites where they are preferably needed. Whereas the excess carbohydrates that we consume, which go to the liver, are converted there into glycogen with the help of insulin, and the excess carbohydrates which cannot be stored as glycogen are stored by de novo lipogenesis into ectopic sites like liver. The central obesity, the visceral adiposity is because of the hyperinsulinemia, and the atherogenosis is because of hyperinsulinemia, causing ectopic deposition of this fat, dietary carbohydrates, into fats. If you look at the fatty liver, if you consider this balloon example where food, when it comes in, the insulin spikes and the food is stored in the liver as glycogen and by de novo lipogenesis as fat, and when we are not eating, the same energy can be broken down when the insulin levels dip. But if there is a persistent hyperinsulinemia, if we keep eating all day round and keep the insulin spiking, we are not giving a chance for this balloon to empty its energy. We are going on continuously feeding this balloon, and that's why this balloon is overinflated. That's fatty liver, because of high insulin continuously keeping us in a storage mode. What happens to such fatty liver people when the insulin levels dip? When the insulin levels dip, the fat in the glucagon in the liver is the glycogen in the liver is broken, and there is a hyperglycemia. The fat and the glycogen is broken and glucose comes in. And if we see this hyperglycemia and deal it with by giving more insulin and pushing that glucose back into the liver, we are worsening the fatty liver. Studies have shown that steatohepatitis or fatty liver precedes diabetes. 18 months prior to the diagnosis of diabetes, we see an increased ALT levels, and that's the long silent cry of the liver because of excess fat deposition that is unable to store more, and we are increasing our insulin levels to further deposit fat into the liver. And that's the reason. And weight loss, caloric restriction, weight loss of over 3 months has shown that there can be a 30% reduction in the liver volume. The fatty liver can be reversed, and 80% of it happens within 2 weeks. On those who had a low caloric diet of 500 calories per day for 3 months, fatty liver was easily reversed. So fasting can be a potent mechanism to reverse fatty liver and prevent onset of type 2 diabetes. As you all know, increased insulin levels are because of increased carbohydrates, and increased insulin levels themselves cause insulin resistance, and insulin resistance leads to further insulin increased levels, and this is a time dependent progressive vicious cycle which also leads to obesity. And which comes first? It's probably the hyperinsulinemia because of our eating habits, which leads to insulin resistance. So insulin resistance, there are two things required: higher insulin levels and the persistently higher insulin levels. So high hormonal levels and the constant stimulus, These are the two things. As you all know, all the hormones in our body are secreted in a pulsatile fashion. Every hormone, whether it's cortisol, thyroid hormone, everything, each and every hormone is secreted at certain point of the day. It peaks, and certain times it comes down. That's the way, natural way, that the receptors don't get tolerance to that hormone, or don't get resistant to the hormone. Insulin also has to be coming in pulsatile fashion to prevent resistance. And persistence of this insulin excess leads to the receptor downregulation and insulin resistance. So pulsatile circadian rhythm. You can understand this from the common example of the nitroglycerin drug, nitroglycerin patch that we use. We don't keep it there for 24 hours because we know if we keep the patch for 24 hours, it's not going to act. It is the body is going to, receptors are going to develop tolerance to it. So we apply it for 12 hours and we give a 12-hour gap to the nitroglycerin patch. In the same way, for insulin, we need to give a significant gap in the insulin peak and the nadir so that the receptors don't get tolerance or insulin resistant. So high levels of insulin. So which are the foods which cause a peak in the insulin levels? The refined carbohydrates, the sugars. These are the fattening foods which cause a peak or a very high insulin secretion. And the persistence of high levels is because of when you eat. So a lot of time has been spent on what to eat and what not to eat, understanding that. And we all know that a pastry and a broccoli, even if they have same calories, are not equally fattening. A pastry or simple sugars or simple refined foods are more fattening than those which are covered with a lot of fiber. So what to eat has been a topic of discussion for a long time, but when to eat to avoid this persistence of insulin levels in our blood has been neglected for a long time. And that's the 50% of the battle, is when to eat and when not to eat. So caloric restriction, we have seen that caloric restriction fails. That's because as you keep somebody on a caloric restricted diet for a long time, the body starts dropping the basal metabolic rate and the hunger starts to come up. The ghrelin hormone goes up. Long time we have been thinking that eat less and move more is the way to lose weight. But we have seen that we have all failed. We lose weight and then again we gain back that weight. So caloric restriction alone is not going to help, because if suppose we were spending 2000 calories a day and we were consuming 2000 calories, if we want to lose weight, we thought that if we eat 500 calories less and we keep spending the 2000 calories, we will eventually start losing weight. So it does happen in the beginning that we start losing weight, but the body doesn't want to die. The body understands that he's eating less and now needs to restrict that ongoing weight loss. So body starts spending less on the basal metabolic rate. If the body was spending 1000 calories on basal metabolic rate, it will start spending only 500 calories on the BMR, and the BMR goes down, the metabolism goes down, and you stop losing weight, and eventually you gain back that weight again. So caloric restriction is not the answer. It's the hormones. Our body has no caloric receptors. Our body doesn't count calories. Our body listens to the messages from the hormones, and what food is going to evoke which hormone is important rather than the calories. Which calories are going to cause hyperinsulinemia, that's important. So fasting causes the insulin levels to dip, and when the insulin levels dip, That's the time when the locked fat stores can be accessed. The locked energy, we can act using two fuels. One is the food energy and the one is the stored energy. Unless we stop the food energy and open the lock by causing the insulin levels to go down, we cannot access the stored fuel. So the insulin levels have to drop. And when the insulin levels drop, they cause surge of counter-regulatory hormones like the noradrenaline and the growth hormone, which eventually which raise the basal metabolic rate and don't allow the BMR to fall. And we all see that fasting, if you skip a meal after you feel hungry, but after some time the hunger dies down. Hunger comes in waves. It comes and goes. It comes and goes. When the body accesses the stored energy and fuels up through the stored energy, the hunger goes down. So the ghrelin goes down. And eventually, after 2 or 3 days of fasting, the ghrelin hormone levels significantly dip down. So fasting, rather than caloric restriction, can deal with these two loopholes that the caloric restriction has. The fasting raises the basal metabolic rate and it suppresses ghrelin hormone. It won't cause you persistently feeling hungry. You lose the hunger eventually on fasting, and you can continue to maintain your basal metabolic rate and continue to lose weight. So weight loss depends not just on what you eat, but when you eat. That's equally important. In 2008 NEJM article, they looked at what we should eat. We have so this article looked at weight loss with low carbohydrate, Mediterranean and the low fat diet. For a long time we have been demonizing fat. So this article, when it looked at which diet has the maximum weight loss capacity, the red is the low fat diet, the orange is the Mediterranean diet, and the purple is the low carbohydrate diet. So low carbohydrate and Mediterranean diets significantly had, over 2 years, significantly more weight loss as compared to the low fat diet. So fat is not as fattening as the carbohydrates. That's a very important message from this study. And not only the central obesity or the obesity, but also if you look at the blood markers of lipid profile, HDL was significantly high in the low carb diet. The triglycerides were significantly low in the low carb and the Mediterranean diet. The Mediterranean diet did show a significant improvement in the LDL cholesterol as well. So Mediterranean diet, which is high in monounsaturated fatty acids and high fiber, is clearly a better diet than the low fat diet. And the fat is not, in our food is not as fattening as the carbohydrates. So what you eat is very important. And 2008, this article looked at NEJM article was looking at this, what to eat. And it took almost 11 years for our scientific community to reach this point of when to eat. And 2019, NEJM published this article of effects of intermittent fasting on health, aging and disease. And that is the point, like almost 11 years later, we started understanding when to eat and how fasting, the 2016 Nobel Prize for Autophagy and Fasting, evoked this renewed interest in this age-old mechanism of fasting and getting the benefits not only in preventing obesity, diabetes, but also in preventing cancers. Autophagy is the mechanism where the body eats itself either for the fuel or for the protein, and the redundant proteins are eaten up and inhibits tumorigenesis. The mTOR, which goes up after consuming of proteins, which also is involved in tumorigenesis. The mTOR pathway can be inhibited by fasting. So intermittent fasting gained entry into the scientific journals in 2019, with NEJM publishing this article where they now understand the benefits of fasting, how fasting leads to increased utilization of the fats in the form of ketones as energy source, and how in a fasted state our decreased insulin levels, decreased mTOR levels, decreased protein synthesis leads to increased autophagy, increased DNA repair, increased antioxidant defenses. And when after you eat after a prolonged fasted state, the switch from ketone to glucose for the cellular at the cellular level, it causes increased insulin, increased protein synthesis, and the like the bones, they don't just have osteoblastic activity or bone formation. Osteoclastic activity is equally important. The destroying of the old bone with osteoclasts and formation of new bone with osteoblasts. If the osteoclastic activity is not there, it's not a healthy bone. So the muscle breakdown and the muscle repair is the mechanism by which we work against aging. We renew our tissues. So fasting causes growth hormone levels to go up. It increases the brain-derived neurotropic factors to go up and prevents Alzheimer's. It prevents muscle breakdown. The growth hormone renews our tissues. So fasting is the most potent time. Like when we sleep, we are in a fasted state. That's the time when the growth hormone goes up and repairs. So repairs can happen most with growth hormone, brain-derived neurotropic factors, and that happens when the insulin level goes down. And at the cellular level, in long-term adaptation with this switch of fuels, we have seen that increased insulin sensitivity, improved lipid metabolism, improved gut microbiota, reduced abdominal fat, reduced inflammation, and reduced blood pressure. So all these benefits we can achieve with fasting. And it's very important, this article also mentions that this fasting has to be included in our medical curriculum as basic science. And our physicians, dietitians, nurses have to be trained in counseling patients in intermittent fasting or time-restricted fasting and prolonged fasting and the benefits of fasting. And we hardly have any lifestyle change centers. So this article in NEJM also speaks about, not only because our clinics are more focused on disease and curing the disease with medication, we need more lifestyle changing physicians or lifestyle changing centers where these intensive dietary managements can be looked into and individualized as per patient requirements. And these are some typical sample prescriptions of intermittent fasting which you can go through the NEJM. But the point is, now the scientific community as well, the NEJM, which is a very reputed journal in peer-reviewed journal in medicine, it also now acknowledges the importance of fasting and reducing insulin levels to gain or reverse type 2 diabetes. And fasting, as you all know, it has huge advantages. It's most of the diets, when we look at, they are very complex to understand. It's difficult to explain to the patients. But fasting has no complexity. Fasting is just not eating anything. It's not a diet as such. It's not eating. And it's so simple, easy to understand. It's inexpensive. There is no cost associated with it. You don't have to go out and bring some expensive foods like quinoa or amaranth and different millets. It is fasting. It is not eating anything, so it's inexpensive. It doesn't need any preparation. If you feel like you do it, if you're not feeling on some day you're not feeling like fasting, you don't do it. It's easy to perform. It's not time consuming. In fact, it's time liberating. It will liberate your time. You get a lot of time to do so many things when you are fasting. And it's the most powerful tool, a time-tested tool for ages. Millions of people have practiced fasting for time immemorial. The Christians, the Muslims, the Hindus, have been fasting for religious benefits for a long time, they don't die. There are benefits associated with it. So the conclusion is diabetes can be reversed. There is evidence for it, and intensive dietary management and fasting can be a most powerful tool in reversing type 2 diabetes and managing obesity. And more evidence will be building up in coming future. Till then, thank you and happy fasting.